Medurstand, Understanding Medicine.
I'm Professor Azizur Rahman, and today we are going to start another series of lectures on valvular heart diseases. And this lecture is, I think, very basic introduction. Although I understand all of you know this, but I think for the sake of completion, I would like to talk about very basic concepts about the heart, the valve. In the subsequent lectures, we will cover all those conditions which are relevant in the sense that these valvular diseases, they still are common, and you are very likely to see one case in your examination because we often keep cases of valvular heart diseases, whether it is an undergraduate examination or is it a postgraduate examination. And two, in your clinical practices, you will be definitely seeing patients, and it is, I think, very important to diagnose these patients well in time so that appropriate treatment can be offered. A good skill, if you have developed a good skill, clinical methods, you should be able to not only pick up the diagnosis, you should, I believe, be able to make the precise diagnosis. That is exactly what we used to do in our times. But these days, since an echocardiography is available, and that is the ultimate in the diagnosis of valvular heart diseases, so we normally tend to go for an echo early. I think that's fair. If we have a tool which can help us to make a precise diagnosis, why not to use it? But I think, as far as I'm concerned, if you know the disease process and you are able to pick up that there is some valvular problem, if you are able to pick up that there is a murmur which is the hallmark of a valvular heart disease, and you can pick up what kind of murmur it is, so you can at least have some idea that this patient needs further workup and needs referral. So I think you need to develop at least that much skill that after careful examination of the heart, you should be able to pick up that there is a valvular disease. All right, so I think definitely I would expect more, but that is the bare minimum. Now let's go through the presentation. The background of this, we have two types of valves. One group is called atrioventricular. Now, atria or low chamber systems, from the atria, blood goes to the ventricles through mitral valve and tricuspid valve. You know, mitral valve is situated between left atrium and left ventricle, and tricuspid is situated between right atrium and right ventricle. And then we have ventricle to great vessels. On the left side, the blood from the left ventricle goes to the aorta through the aortic valve, and on the right side, blood from the right ventricle goes to the pulmonary circulation through the pulmonary valve. Now these valves, they have different structure. The valves which connect atria and ventricles, they have different structure, and the valves which connect the ventricles with the great vessels, they are of different structure because these have to sustain higher pressure as compared to these one. These are generally is bigger in size, but relatively they face less pressure, and these are relatively smaller in size, but they face higher pressure comparatively. Then we have this classification, another way of looking at the same high pressure system. And of course, the left-sided system is high pressure because that supplies blood to our entire body, our brain, our muscles, our legs and arms and entire body. So left-sided pressure is a higher one. Mitral and aortic, they belong to high pressure system. Now, why it is important to classify them like this? Because these high pressure system valves are somehow more prone to be damaged. In rheumatic heart disease, in rheumatic valvular heart disease, the commonest valve which is affected is mitral, and the second commonest is aortic. In fact, aortic is usually in addition to mitral. And isolated right-sided involvement in rheumatic heart disease is almost impossible. I think it is always a left-sided disease which is present in rheumatic heart disease because of high pressure, I believe. Then we have low pressure system on the right side, tricuspid valve and the pulmonary valve. So valves on the left side are more likely to be damaged in some rheumatic process and also in infective process as compared to the right side. Now this picture shows you the normal blood flow, and you can see that the blood is received from the periphery and first it goes to the right atrium, and this is the tricuspid valve, and the valve between right atrium and right ventricle, the tricuspid valve. It comes to the right ventricle. From the right ventricle it goes to the pulmonary artery through the pulmonary valve. This is the pulmonary valve, and then it would go to the lungs, and from the lungs, it after getting oxygenated, it will come to the left side, and through the pulmonary veins, there are four of them, the blood is brought back to the left. Certainly you can see the change in the color because this is venous blood and this is the oxygenated blood, arterial blood, and from left atrium to left ventricle, and then from left ventricle to aorta. This is mitral valve and this is aortic valve. Now, as these arrows show, blood flows only in one direction. So blood from the right atrium will go to the right atrium to the right ventricle, and during surgery it never goes back, it only goes this way. Once it has gone to the pulmonary artery, and then these valves will close and will never come back. Similarly, on the left side, after the blood has come from the left atrium to the left ventricle, then it will never go back in the normal state, and then from left ventricle it to go to the aorta and then never comes back. So if there is obstruction, like for example, blood is unable to go from this chamber to this chamber, or from this chamber to this chamber, or this chamber to this chamber, or then this chamber to this chamber, then that is called a stenotic lesion. But if it goes back, for example, if the blood goes back from the right ventricle to the right atrium, it would be called regurgitation, incompetence, because the valve doesn't close. And if the blood goes back from the pulmonary artery back to the right ventricle, it will be again regurgitation. From left ventricle back to the left atrium, regurgitation. From the aorta back to the left ventricle, regurgitation. So if blood has difficulty going forward because of a narrowed valve, that is a stenotic lesion. And if blood is going back when it should not go back, and that is a regurgitant lesion. In many situations, we have combined stenotic and regurgitant lesions. Uh, Etiology and pathology. Rheumatic is the process in our part of the world. The commonest cause of valvular heart disease is rheumatic. In fact, I would say that if you do not have any clue to the etiology, you can simply assume that this is rheumatic. What is rheumatic? In the childhood, if there is rheumatic fever can recover completely or may leave behind some valvular damage, which is very slow and progressive. And typically, after years and years or maybe decades, patient develops valvular stenosis or regurgitation, then patient becomes symptomatic. So unless there is evidence of something else, in our part of the world, we assume that any valvular disease is rheumatic. But then there are congenital. Of course, congenital valvular heart disease definitely exists. In the West, congenital heart diseases have superseded the rheumatic heart diseases because they can diagnose rheumatic fever early, they can treat rheumatic fever early, and they actually, because it's a complication of some infection, rheumatic fever has become very rare in their societies. So they see congenital heart disease more common. Of course, the West also has the immigrant population. They would still see some rheumatic heart disease. Then there's a concept of degenerative. That means with time, the valves tend to wear off, like any structure, like our knee joints wears off with time. Other things, they wear off with time just with sheer trauma. And these valves can degenerate, like there could be aortic valve damage, there could be other valve damage. So I think with time, degenerative process. There are certain diseases in which this degenerative process becomes faster. Because these valves consist of connective tissue, so that's why there are some connective tissue disorder where these valves, they can degenerate rapidly, and this degeneration is actually uh, progressive and comes with age. Sometimes we also call them senile valvular disease. Then infective. If somebody develops infective endocarditis, uh, normally, especially in our part of the world, infective endocarditis develops only when you already had valvular heart disease. But in these days, when there is the prevalence of intravenous drug use has increased, there could be infective endocarditis with normal valves also. So infective endocarditis can lead to damage to a valve and could result in typically valvular regurgitation incompetence. And then trauma, of course, especially in certain people who have this connective tissue problem, even some trauma, even some blunt trauma to the chest can cause a valvular regurgitation. And then prosthetic valve malfunction. Uh, of course, a prosthetic valve could malfunction and it could result in stenosis, or mostly it because of dehiscence, it results in degeneration. So I think at first level we have to make a diagnosis of valvular disease in terms of stenosis or regurgitation. Regurgitation is also called incompetence. And then we have to make a diagnosis in terms of the etiology, if possible. And then, of course, we have to make a final complete diagnosis with the help of echo, because echo will tell you almost everything you would like to know about the valvular heart disease, like which valve is affected, how much is it affected, how much is narrowing, is there any scarring, is there any vegetation, is there any clot formation. So I think everything you want to know, that will give you truly a complete picture. Echocardiography is a great tool for the diagnosis of valvular heart diseases. So I think uh, whether congenital heart disease or valvular heart disease, echo plays an extremely crucial role. Now, all these four valves, the function of the valve is to open when it has to. I mean, the atrioventricular valves, they open during diastole because ventricles fill in during diastole. And the pulmonary and aortic valve, they open during systole because then the blood is ejected into the great vessel during systole. And so these are the times when these valves have to open. And if they cannot open, or if they do not open properly, that is called stenosis. So any of the valves, mitral, aortic, pulmonary, tricuspid valve, may be stenosed. That means when they have to open, they do not open properly, or they do not open fully. And the second function of the valve is to close when it is not supposed to open. So it is supposed to remain closed. The mitral valve and tricuspid valve, they need to close during systole to allow blood to go to the great vessels rather than going back into the atrium. If they do not close during that phase, that would result in regurgitation. That means the blood has regurgitating back into the chamber. In case of mitral, it will regurgitate back into the left atrium. In case of tricuspid, it will regurgitate back into the right atrium. So this is incompetence. If you take the example of aortic and pulmonary valve, in that case, if these valves do not close, it will result in aortic regurgitation during diastole and pulmonary regurgitation during diastole. So you can have actually in any valve, all the four valves, you can have anything. You could have pure stenosis or pure regurgitation. But I think more appropriately, I would say it would be predominant stenosis or predominant regurgitation, because any disease process would actually destroy the valve. And if the valve is destroyed, it would most probably affect both its opening and its closure. So I think mostly it would be combination, although in some cases it would be predominant stenosis and in others it would be predominant regurgitation. But majority, I tell you, especially when you do echo, majority you'll find that it is actually a combination. Now this is extremely important. This is extremely important. Somebody with mitral stenosis, pure mitral stenosis, the treatment may be different than another person who has mitral stenosis along with very significant regurgitation. So that is why we need to know this. So in the subsequent lectures, we will be discussing all these conditions. Of course, it will not be possible to cover all of them, but I would be talking about mitral stenosis, mitral regurgitation as two separate lectures, aortic stenosis and aortic regurgitation as two separate lectures, and maybe in then one lecture we will cover the other valve, the pulmonary tricuspid. So stay with me. I'm going to cover all important conditions. Remember, these cases are important for you because may it be undergraduate or postgraduate examination, you are surely going to encounter a case with valvular heart disease. And in your practice, you need to handle these patients very carefully. You don't want these patients to be missed and ending up with complication. For that, I'm really looking forward to see you in my next lecture, which is going to be on mitral stenosis. And this is Professor Azizur Rahman from Medurstand. Thank you.